Today I will introduce my experience and some concept to approach this kind of therapy. Autologous regenerative therapy is an autologous homologous microfragment adipose tissue graft. It carries the power of stromal vascular fraction, mesenchymal adipose-derived stem cell, and growth factors and exosome to regenerate the skin, restore the volume and the subcutaneous tissue. Go. As you can see in the picture, go. We can treat the loss of volume, the skin aging, and the crescent tissue. Go. As you can see in this video, before and after. Move on. Move. Okay. We can regenerate the skin, as you can see, but also we can restore the volume. Move one. The tissue graft that we take off from the donor site contains adipocytes, stromal vascular fraction, granulocytes, endothelial hemopoietic monocyte lymphocytes, and also stromal vascular fraction, fibroblast, pericyte, preadipocyte, move on, and exosome. So different kind of cellular line, but also growth factor and exosome. The property, move. The property of differentiation of the line, the cell line in adipocytes, chondrocytes, osteocytes. They can produce collagen and GAG by fibroblast and the angiogenic activity from a vascular fracture, and the important property to treat the chronic disease, the homing property, the migration to injured area, antifibrotic activity, and immunomodulating activity. The exosomes are nanovesicle derived from multivesicular endosomes and secreted by the cell. Exosomes bear various biological molecules, including proteins, lipids, and RNAs. Exosomes mediate the language between cell to cell, the communication, and are the important, the autologous exosome derived from the autologous cell because know the same language between the interchange, communication between the cell, the growth factors, and the to maintain the body homeostasis. So they are important. We are working in a study in vitro. Move on, please. Move the slide. In vitro, we demonstrate that fibroblast treated with exosome obtained by fragmentation tissue derived from Cepheid methodic show a 33% grade increase in production of hyaluronic acid, collagen type 1, and elastin, 33%. And it is an important opportunity with this kind of therapy to prevent the skin aging, to treat the skin aging, but also to treat the chronic disease such as atrophy, fibrosis, scar, and some other pathology, cutaneous pathology. The kit is all in one, so can you move slowly? You are too. Can you come back with the slide, please? Back. Back. Okay. I see to you when you move on. There are a lot of kind of donor sites, but in my experience, the peritrochanteric area is the more safer and more rich of tissue graft. Contain microfragment adipocyted, stromal vascular fraction, exosome, and growth factors. We take off the cluster of tissue with a small cannula, 2 millimeters of diameter, and this allows to make a fluid fat graft that could be injected in different kind of area. It depends from the fluidification between the two syringes that we pass the tissue. Move on, please. Okay. Which are the difference from the other device in the commerce, in the market? Most of the old technique need the manipulation of the fat between circuit, between mechanical manipulation that died the cell, killed the cell, and the cell shaken between the mechanical wall of the dispositive lose a lot of property and we lose a lot of growth factor, but the small molecular are the exosome. They are the first part that we lose when we manipulate the fat. But as we can say before, the communication between the cell is mediated by the exosome. So with the old technique, we lose a lot of signal to communicate between the cell. So this kind of methodic is the goal is not a lipofilling, but is a regenerative therapy because the most part of this tissue is cell, growth factor, and exosome. A small part of this tissue is adipocyted. So the treatment is therapeutic, is curative, not volumetric. Is a cluster selection because we have adipocyte, stromal vascular fraction. Move on, please. Okay. Stromal vascular fraction, growth factor. So we fertilize and sow tissue. It isn't a PRP. PRP is only growth factor acellulated injection. Move on, please. The cannula, we use a small side port holes cannulas. It's possible to inject superficially the fluid fat without manipulation. We can pass between 8,000 micron to 2,000 micron, and it's allowed to fluidificate the tissue to inject with a cannula, but also with a needle. Move on. The disposable is made of a syringe with a guide, so we can stay in the 15 millimeter up under the skin, and we demonstrate also in the literature that in the superficial adipose tissue we can find a lot of kind of an heterogeneous population of cell. So if we stay superficial, we can pick up a lot of kind of cell, growth factor, and exosome. If we keep the tissue from the deep adipose tissue, we have a lot of adipocyte, and we don't have cellular population.
You have 5 minutes
okay.
left.
We are a lot of literature move. So art is dose dependent. Move on, please. Move. Dose dependent, standardized, and scientific evidence. Move. Move on. With different kind of fluidity, we can inject it. Move on. Different area. Under the orbicular, dermal layers, above the temporal fascia, superficial subcutaneous tissue. Move. As you can see in this picture, before and after. Move on. The picture, you can see the decline time 0 after treatment 45 days, 1 year after. The results are stable for 1 year. Move on. In this picture and this video, you can see also the improvement of the marks. Move on. As you can see with the image acquired with the Vectra system, the decrease of hyperpigmentation after 3 months of treatment. Move on. Move on. We publish a multi-center study with 2,300 patients in different centers. Move on. And move. We combined it, okay, in this short video. Go. Is resume the procedure from the peritrochanteric area. We remove superficial fluid fat graft, then is by decantation ready to be injected in the different kind of tissue. Move on. This is a patient treated before and after. We improve the mandibular line, the skin quality, and the global quality of skin. Move on. This is another clinical case. We redefine the mandibular jawline and also the skin quality. Move on. So, regenerative medicine, reshape, restore the volume, redensify the layer, and regenerate the skin. Move on. We can also treat the alopecia androgenetic with this methodic. The best result we obtain by combination with the carboxy therapy. Move on. 3 or 4 sections of carboxy therapy propedeutic to the injection. Move on.
2 minutes left. You have 2 minutes left.
Okay. Move on. Move on. Move. Okay. This is a clinical case before and after 3 sections of carboxy therapy, art section, and 2 sections after of carboxy therapy. Move on. We can also combine the treatment with some other dispositive or with other technique. Move on. With the hyaluronic, in association with the hyaluronic acid, hydroxyapatite, also with carboxy therapy, laser, and 3 heads. Move on. Move. This is a patient treated with, in combination, hyaluronic acid and the regenerative therapy. Move on. Move. This is a young patient treated with the combination of regenerative medicine and hydroxyapatite. Move on. This is a combined technique with laser, treated before with laser. Move. Move on. This move. With the endolift to tighten the sagging skin, then the patient was injected with the autologous regenerative therapy, 9 cc per side. Move on. This is before and after treatment. Move. Another case. We can treat also the scar with laser and then injecting with the regenerative therapy. Move. We can also, with carboxy therapy, we can turn the mark. Move. The complication after surgery, was necrosis of CAC, treated before with carboxy therapy, then with regenerative. Move. This is a radiotherapy complication, treated with carboxy therapy and regenerative medicine. Move.
Doctor,
And this is the last one. It's a necrosis treated of the CAC, treated before with carboxy therapy, then with heart. And the last one, move. We can also treat the